Yes, absolutely. And thank you so much to Mary and everyone, like she said, for being here. I am so happy to be here with you today, and I'm so excited for our presentations. I am going to talk fast so we can get to everything. I have a few sort of housekeeping items just to get us started. So you all should have received an email from Gift Card Granny last night with a $10 gift card to put towards your lunch today since we are virtual. It is not spam, so please look for your email if you haven't seen that already. We will be muting people. I think we're all used to this by now, but just so you know, we'll be muting, especially if there's some background noise. We will also be monitoring the chat. So if you have any questions, we will address them in the chat. Please put them there. Or if you want to send a direct message, that's fine too. But we will be monitoring the chat. We will also be sending a follow-up email with all of the information and documents shared today. So if you missed something in the chat or are having a hard time deciding which breakout to go into, we're recording everything and we'll share that in a follow-up email. So be watching for that next week. And then finally, there's an evaluation for today's event that'll be shared at the end of your breakout session. And also in that evaluation, or I'm sorry, in that follow-up email, your feedback is really helpful for us in planning this next year and for future events. You all are the backbone of mental health first aid, and so your feedback is really critical and we take it very seriously. So make sure you watch for the evaluation. And now I would like to introduce the rest of the Mental Health First Aid Maryland team at the Mental Health Association of Maryland, some of whom you already know. We have our two wonderful mental health first aid coordinators, Leah Bentfield and Indu Radhakrishnan, who are fantastic instructors themselves. They lead important initiatives that we'll talk about today, and they coordinate all the behind the scenes work that keep our trainings going. So huge thanks to them. We also have our fabulous lead Maryland instructor trainer, Ann Hamel, who works with our Maryland cohort of instructor trainers and supports the team with her wit and wisdom. And we are so grateful to have her as well. And so that is our team, and we're so happy to be here with you today. So I think we're going to go over the agenda really quick. If we could put that up on the screen, just so you all know what to expect, and then we will jump right into it. So let's see. So we're starting with some mental health first aid updates to keep everyone in the loop, make sure we're all operating with the same information. We will do that until around noon, where we will transition into a keynote address from Dr. Holly Wilcox, who's going to be talking about the critical issue of youth suicide prevention. At 1 o'clock, we're going to go into breakout sessions. Again, these will all be recorded. So if you're having a hard time deciding which one to go into, we'll share the videos at the end or in that follow-up email so that you can see any of the ones that you missed. At 2 o'clock, there is an optional networking activity. This is a chance to connect with other instructors in your region. So if you're interested in sticking around for that, come back to the main room. And if you are not interested, you can leave after the breakout session, after you finish your evaluation. So that's sort of how the day will go. Since this is a short event, there are no breakouts, there are no breaks scheduled. So please feel free to step away if you need to take a break. Again, everything will be recorded. So if you come back and you feel like you missed something critical, you can review those videos later. And so without further ado, we will jump right into our opening remarks. And I am passing it back over to Leah to get us started.
Wonderful. Can you all see my screen? The green box didn't show up, so I just want to confirm that.
Yes.
Wonderful. All right, so as Mary kind of referenced, it has been quite the year. There have been so many changes to mental health first aid at both a Maryland and the national level. And we do want to just take a moment to appreciate that you all have been along for the ride and have navigated it with grace and patience. And we look forward to moving hopefully into a year of just familiarity and calm moving forward. At least we can hope. So a year in review. We met last year in June for our summit. And then we kind of launched into summer season, which started with a rebrand, a national rebrand in August. In October, we said goodbye to the instructor portal and Cornerstone, our old LMS, and moved into Mental Health First Aid Connect. And everyone has thoughts and feelings about Connect, but we know that it has improved and changed and adapted in only the last 6 months that we've been working in it. And we really look forward to all of the possibilities that Connect can bring moving forward. For those of you who have started instructing in the last couple months, you are the first kind of generation to just exist within Connect, and it has been fun to see people grow and learn alongside that program. In January, we saw the announcement for the second edition in-person curriculum finally released. So that is a self-paced module. If you are interested in taking it and have not yet, you should see it in your Connect account. If it's not, you can submit a request assistance form to get that loaded into your account. Like the other onboarding material, it takes about 2 hours to review. It is, from my understanding, pretty similar format to the first edition in person, and is quite different from the virtual and blended. So make sure you spend some time if you're interested in instructing in person in the next year to review that, to sink in. And we will also be offering some ongoing webinars to kind of, parse out the differences between the curriculums and get really familiar with that as we go through the year. In April, we had our first national summit in person for the last couple years, I think for 3 years. So if anyone was down in DC, it was fun to see people in person for the first time. And there were some announcements that came out of the summit, including some pilots and supplements and a timeline of what the National Council is hoping to produce for instructors this year. And we'll look a little deeper into that in just a moment. And then last but not least, I don't know if anyone's been reading their emails the last couple of weeks, but the announcement of the Submit a Course feature in Connect, which will help people reach unwired communities along with, our police and emergency services and folks who are not able to do a lot of that pre-work online in Connect. It allows the instructor, kind of old school style, to upload that information instead. So we grow, we change, and it has been an exciting, jam-packed full year. From the National Council, we also have some very exciting updates on the horizon. We have translations into several more languages than originally had in our first edition curricula. We have cultural considerations, inserts, so more information that can be just plugged into an everyday mental health first aid course. Some teen updates and curriculum supplements. Those are the ones that we are waiting patiently for to get that secondary accreditation so that you can teach to those specific populations. So these things are all on the horizon. This was information that was shared in April, so hopefully we'll see more and more updates as we continue through the year to get all of this exciting information from the National Council. We are going to transition a little bit into now just focusing into Maryland. So I don't know if everyone is familiar about our relationship. It's pretty special with the National Council, but Shauna will share a little bit more about that.
Yeah, thank you. So as one of the founding partners that brought mental health first aid to the United States, the Mental Health Association of Maryland is the only organization that can provide instructor training to people who live and work in Maryland. And so we work very closely with the National Council on Mental Wellbeing to ensure that training is aligned with national standards. But in case you were ever confused about why you get emails from both of us, that is why. We, again, work very closely with the National Council, but we are the organization and team who bring instructor training to Maryland. And in that role, we are really committed to share mental health first aid training as far and wide across Maryland as possible. And so we are so grateful to work with you all to make it available in as many of our communities as possible. Mary talked about this in her introduction as well, but as we all know, mental health needs have really skyrocketed over the last couple of years through the pandemic, continued racial and social justice movements, economic struggles, in a challenging political climate with major news stories coming out, what feels like every day. And people are in need of support. In mental health first aid, Maryland has redoubled its efforts to expand the reach of mental health first aid. We're going to talk about some of our special initiatives a little bit later. But we plan to continue to expand and improve our work and want to make your role in this training as easy and accessible as possible. And so that is our commitment. And go ahead to the next slide. We're going to talk a little bit some of our program goals for the next year and ongoing, really. But we are trying to remove as many barriers as possible to obtain mental health first aid certification. And so whether that's applying for funding to offer it for free or for lower cost, or working with employers to train their staff, we're working really hard to make it as accessible as possible. Of course, we are also working really hard to support trainers and instruction so you can continue to provide the high quality instruction that you are all providing. And so we want to support you in doing that, whether it's improving technical assistance. You know, Leah talked about Connect, which is a really great tool, and it is, you know, a new tool to learn. And so we want to be supporting you in doing that, and providing continuing education and relevant content, making sure you have access to each other. So please stay tuned as we continue to make some changes and improve our offerings. We are continuing to partner with communities and organizations interested in implementing mental health first aid. This continues to be a critical piece of our work and something that we will be talking about a little bit more today and will continue to share as that evolves. And then finally, we know that mental health first aid is an evidence-based program, but we are invested in making sure that we're getting the best outcomes possible in Maryland by evaluating various aspects of the program. So stay tuned for more of that as well as we continue those efforts. And if you go to the next slide, we want to give a special thanks to all of our partners. In this past year, we've been so grateful to partner with many national, state, and local organizations, which allows us to offer mental health first aid either for free or reduced cost to community members. And we are so proud to be partnering with educators and campus communities, first responders, faith communities, and organizations that are committed to training their employees. So we wanted to give special thanks to our partners who are making this training available. And so here, just, you know, you can see some of the special initiatives and organizations we've been working with this past year and hope to continue to grow this list. And if you go to the next slide, we could not do all of this work without our incredible Maryland trainers. So please give them a big shout out. Many of you are probably trained by one of these incredible mental health first aid ambassadors. They are here today. Some of them are presenting in breakout sessions. They partner with us on several of the special initiatives that we talked about in the partnership slide before. And so we are just so grateful for their skills and knowledge. And I want to thank them all for being here today. And so go ahead to the next slide. I think I'm passing it off to Leah now to talk about our year in review.
Yes, so as we mentioned, it's been quite the year for the National Council and all of us instructing with them through mental health first aid. We also wanted to just shout out some really exciting updates that have impacted Maryland and all of us instructing throughout the state. We at MHAMD a year ago brought on a third person, that was me, to help work with Anne and Mary, who were pretty much single-handedly running this program. Thousands of instructors, thousands and thousands of first aiders supporting anyone and everyone as much as possible. And we are very thankful to have brought on 2 additional people in that time for Mental Health First Aid Maryland, Indu and Shauna and have 2 additional staff members. This just shows you how much the need for mental health first aid is growing in the last year. We'll be bringing on 2 additional staff members in the coming months. So we are thankful for your support and patience as we are rapidly growing our team to meet the growing need and the existing need of mental health first aid for instructors and our first aiders. We also have launched this year weekly instructor office hours. So making sure that we are available to you for support regularly, twice a week. We can drop it in the chat, the link, if you're interested in joining us for office hours. It has grown and changed a little bit to better meet everyone's availability in the past year. But if you're able to schedule 30 minutes with us, we are able to meet with you and dive into any of those questions or review any of the information or the changes in the curriculum. We are happy to do that on a one-to-one or a small group if you're interested in that as well. So please make sure you are joining us for those office hours. We've been providing nearly monthly professional development opportunity webinars, which are both need-based. So we've been able to talk about teen and the launch of Connect over the last year, but also some very interesting just professional personal development, like nutrition and how it impacts mental health first aid, social media on the teenage brain and those impacts, and as well as how substance abuse impacts or substance use impacts our first responder community so significantly. So those are some of the webinars that we've been able to support and offer, and we look forward to getting your feedback from this evaluation today and being able to plan more of those in the coming year. So as Shauna mentioned, make sure that you are filling those out so that we can use that information to better support you. We have Maryland trainers and MHAMD have been able to offer mentorship opportunities, something that we're hoping to model more of our engagements after in the future. So we have been able to pair over the last couple months due to one initiative with one of our local funders, our Maryland national trainers with new instructors. So you get that hands-on support for that first training. And after a while, you're able to move into that mentorship role in order to provide ongoing support to the next cohort of new trainers. So look out for more of those opportunities for mentorship, for training. And we are really, really excited to be able to incorporate some more of those opportunities in our coming year engagements. We, in January, launched our initial conversation around teen mental health first aid in the state and have been excited to start discussing what those implementation sites are going to require and need in order to support an ongoing teen program. So if you are interested in learning more, talking about implementation and what those requirements are, we are going to direct you to Hamel, whose email will be dropped in the chat as well. She'll be able to kind of guide you through what those first steps are so that we can plan for the coming years to get that new curriculum in the hands of young people and the folks that really, really need it. We have instructor retention project. We talked a little bit about evaluation and research, and we are determined as the teaching requirements are put back into place in the National Council within the next year or so, they suspect. We are not sure. But we want to make sure that you are feeling like you're able to meet those requirements. And we want to make sure we are meeting you halfway. So you may be reached out to for evaluation. It is, again, not spam. We're not trying to spam you with anything other than gift cards and your knowledge. So please, if you're interested in providing that information, you'll see emails at some point. And then last but not least, some recognitions and celebrations. We would not be here without you. And we want to make sure that those of you who are doing the hard work day in and day out in your communities are celebrated and recognized for that work. So we've been collecting recognitions over the past couple weeks, and we'll be sending out those emails with all those people's kind words to any of the instructors who received a recognition. We want to make sure to share those out and you will get a little certificate recognizing you as an incredible instructor in the state of Maryland. So stay tuned for that email. And we are incredibly excited to move forward with more recognitions moving forward. Maryland specifically, we looked a little bit at what the National Council has done with us over the last year, but just to focus on the work that is being done in this state. Through the life of the program, nearly 70,000 first aiders have been certified since 2008. So we are incredibly excited to have both the adult and youth program in Maryland and the soon to be teen to help contribute to more and more people having this education. In Maryland alone in 2021, 10,000 people were trained in over 800 classes. If you look at this graph to the right, you can see that in 2016, 17, 18, 19, we were growing, we were expanding, all things were good. We all know what happened in 2020. We can see it on the graph. But I just want to point out that in between 2019 and 2021, we actually beat the number of classes that we were hosting in Maryland by 9 classes. So there were 800 classes in 2019 offered, and in 2021, 809. So give yourselves a round of applause for a comeback story. I cannot wait to see how the numbers play out for the rest of 2022. 2 Maryland instructors, 2 of our national trainers actually, were recognized as top instructors in the country. So I do want to give a shout out to Javon Billups, who I know is here today, and I believe Dave Brown, who is actually teaching today, of course. Both of them were nationally just teaching so much that the National Council was like, let's make sure everyone knows it. So shout out to both of them. And then to kind of shout out those of you who are likely, there's a large number of folks who are new in the room who have just recently received their mental health first aid instructor certification, because we have rapidly expanded the ability to train instructors as well over the last few years. A small snapshot of 2019, we were offering 12 trainings a year. 2020, 7 trainings. And then in 2021, a total of 26 instructor trainings. So we are incredibly excited to have a large and growing cohort of people who are excited here and ready to teach in the 2nd edition curriculum, which they've known nothing other. And then as we move forward, I don't want everyone to think, oh, I won't have a job at any point teaching mental health first aid because we're going to run out of people at this rate. I do want to point out that 70,000 first aiders is about 1% of Maryland. So there is a lot of work, exciting work to be done. So don't fret. We're here. We're going to stick around for a good long time getting this training out to everyone. In the coming year, we are going to work on just familiarity, comfort with the LMS, with Connect. We're going to continue working on expanding our teen reach throughout the state of Maryland. So again, you can connect with Hamel if you're looking for more information on that. As mentioned, research, evaluation, marketing, making sure that we are reaching all of our first aiders on all the corners of Maryland, along with making sure we're supporting instructors to the best of our ability. And then more opportunities to teach, co-teach. We are able to say that we have some really cool things coming towards Maryland in the coming year, and we are excited to be able to join in partnership with all of you to make that happen. If you have any questions, Indu and I are the first line of defense for questions. Please direct any teen questions to Anne. And then again, those office hours on Tuesday afternoon, evening, and then Wednesday midday. Hopefully one of those 2 times works for you, and we will see you then. And with that, I think I'm going to throw it back to Shauna, who's going to introduce our keynote. I apologize, I went 1 minute over.
No, that's fine. And I think if I'm not mistaken, there's another trivia
Right.
question. So I'm going to pause for a minute and then we will get into the keynote.
That's right. Okay, so same rules apply. First person to put it in the chat, the right answer gets the prize. So according to Mental Health First Aid International, how many countries is mental health first aid taught in currently? Wow, Julia, fast, quick on the draw. That's the correct answer. It's 26. So Julia, I'm going to private message you for your email address, and we will get that gift card to you after the summit. And now I'll pass things over to Shauna to introduce our keynote speaker.
Yes, so while Dr. Holly Wilcox gets her slides on the screen, please join me in welcoming her. She's a professor at the Johns Hopkins School of Public Health. She is an expert in population-based prospective studies of suicidal behaviors and has studied the effectiveness of community-based programs. Most recently, she is translating research into practice, which is so important and helpful, and advocating for a public health suicide prevention agenda along with several national and international organizations. And so we are so pleased to have her here talking about youth suicide prevention. So thank you, Holly. Oh no, my intro didn't go long enough to let you have to get your slides up, but no rush. We are excited to hear from you and look forward to seeing this.
So can you see my slides or no?
We
Now
can
we
see
see
files.
Holly.
Oh, you're see files. That's not good. Okay, let me try again. Oh, here we go. Sorry about that, guys. Hopefully now it's working.
Yes.
Yay, thank you. Well, I am really just so thrilled to be here with you all today to talk about the teen program, Teen Mental Health First Aid. I have had the pleasure to work with this program and being part of a team adapting it from the Australian version to the version that is being, I guess, rolled out in the United States. So I am here today to talk a little bit about the context, being myself from Maryland and have been living here for a long time, have children attending school in Maryland. And so I really am invested in this work. And I am also extremely thankful for the work that all of you do in the community in implementing and getting these programs out to people who need them and recognizing people at risk. I'm really excited to be here today. I also want to say that I co-chair the Suicide Commission with Eileen Zeller. And so I also kind of bring that perspective to the table in the state of Maryland. In terms of disclosures, you can see some of the funding that we have here that I'm reporting. I'm an employee of Johns Hopkins University. And one important thing to say, a couple important things to say is that I am a member of the Maryland School Board, but I'm not speaking in that role today. And I also am a mental health first aid research advisor. So I'm part of the team that's called on to help with various research priorities and establishing the evidence base. I think I don't need to tell anyone on this call because I know you're all working in the field and aware of this, but the Surgeon General published a report not too long ago in December of 2021, outlining the children's mental health crisis that we're in, using data and recommending some actions that policymakers and others can take. And really sort of talking about prior to the pandemic, the rates increasing and the problem that we were in with rising mental health concerns in youth, and then the pandemic exacerbating the mental health conditions that many young people were facing. Also, there have been a number of groups that have also tried to prioritize this area and draw attention to it. The American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association in the United States. And some hospitals and healthcare systems have also had a sort of a state of emergency in terms of emergency department visits that youth were being seen for suicidal behaviors and other mental health issues. So we are in a time where this type of work that you're doing is needed more than ever. And just in terms of, where there's a lag in the suicide data, the national data. So the most recent we have is from 2020. But here you can see, if you look at the green boxes, this is the 10 leading causes of death by age in the United States. And you can see that in the green boxes, you'll see the numbers of suicide in these various age groups. You can see that suicide is the second leading cause of death through 10 to 14-year-olds. And through 25 to 34-year-olds. And there's been some fluctuation back and forth between second and third leading cause of death, and that happens by year. But you can see the situation that we're in terms of suicide, and it has been, the pandemic, I think, has been especially rough in many places of the United States in terms of youth suicide. The other piece of data that I wanted to show you that's from the CDC, and these are slides from the NIMH that were loaned to me. If you look at this pinkish red line, this is showing trends in suicide rates by age over time. You can see this increase, this steady kind of increase that we've been experiencing in the suicide rates in the United States. And we are not seeing that same type of trend in older groups. And you can see it's similar if you look at the orange line. You can see that's for 25 through 34-year-olds. So you can see a similar type of trend, although the accrued rate's higher in that older group. Just some key statistics. And, one thing I love this figure, and what this figure shows is the age group in years and the rate per 100,000 of suicide. And you can see this really steep increase for boys, and the blue line is for males, from around the age of, late childhood to young adulthood. And this is something that keeps me up at night, when thinking about the work I do for suicide prevention, just this rapid increase in childhood, adolescence, and young adulthood and suicide among boys. And this has been persistent, that for years, we've seen the same type of really steep increase. And that's something that's actionable for all of us. And to me, that tells me when you recognize somebody at risk, it's important to take action, because we could potentially modify this trajectory and decrease it, which is what we're trying to do nationally and locally in Maryland. And you see a similar, really steady increase in older adulthood for males, and there are different risk factors, as you all know well. Some similar, some different risk factors at these different points in the life stage. And we see somewhat of a different pattern in women in terms of their peak period of risk for suicide. Now we're going to turn, and I'm going to show you some of our data from the CDC Youth Risk Behavior Surveillance Survey. And one emerging issue that we've been experiencing in the United States and locally in Maryland is that the epidemiology of suicide has been shifting. And we typically think of this as a white person, an issue in white people, that they die by suicide, or even Native American Alaska Native individuals we always think of as at very high risk. And what we're seeing more recently, and especially in the pandemic, is that other groups are seeing these rapid increases in suicidal thoughts and behaviors. And here you can just see in this figure, you can see the overall percentages of people reporting, of young people in high school reporting seriously considering attempting suicide, making a suicide plan, attempting suicide, and suicide attempt requiring treatment. But also it's important to point out this Native American Alaskan group has persistently been high, and this is not across the board. There are some Native American, Native Alaskan groups that have very low rates, and some with very, very high rates, much higher than the national population. And this Asian group is one other group that we want to point out in terms of looking at the high proportion of seriously considering attempting suicide. And you see somewhat of an interesting trend for Black and African American youth in that the proportion with seriously considering suicide is 17, but the attempts are almost very similar. So 12%, which we're really close compared to some of the other groups. So what we think of as actionable, like if we know somebody's ideating, thinking about suicide, if they tell us that, that's an actionable thing for suicide prevention. But if they don't tell us, that's not as actionable. And so this idea, and Michael Lindsay and some other leaders in this area of Black youth suicide have really been digging into the data and showing that it's a different pattern, that some young Black individuals go directly to an attempt and do not report ideation or do not experience ideation in the way some other groups do. But worth mentioning because, in our state, we have such a diverse state, and it's important to keep these emerging trends in mind. Also, somewhat similar patterns you'll see for ideation in Latinx youth, slightly lower proportion with attempts. And then the group that I really wanted to kind of bring your attention to that always is typically never a priority because we don't have the numbers to really look at them, is this multi-ethnic, multiracial group. Unfortunately, as a field, we don't really know the needs because they're often not represented in the data. And so I think we all have to keep this group in mind, that their needs are not often known or met. And this multi-ethnic, multiracial group has really quite substantial rates of reporting ideation and plan. And it's a group that we should be digging in and trying to learn more about and trying to work with more in terms of our intervention efforts. Another thing that has happened in the field that's been really exciting is that the World Health Organization has released their Live Life Guide, which is an implementation guide for suicide prevention in countries. And the reason why I like this is because resources for suicide prevention are always an issue, and resources in general for mental health. And so the WHO was thinking about low and middle income countries and what types of things countries can do that are not too expensive, that are not too heavy of a lift. And I like that the World Health Organization pointed out that as one of their few priorities, and they boiled it down to 4 priorities. And one of the 4 priorities aligns beautifully with the Teen Mental Health First Aid Program, improving children's social and emotional competencies and fostering social emotional life skills in adolescence. And I was recently at a conference, and I go to these conferences, and sometimes you kind of, it's kind of like this, oh, the death by PowerPoint. But there was a speaker that was there from China, Michael Phillips, and he said a quote, and I'm just going to read it to you because I really loved it so much, and it aligns with the mental health first aid program in general and the teen program, but we need to shift the current emphasis of suicide prevention efforts on research about individual-based psychosocial interventions to include more research about community-level interventions that act earlier in the causal pathway to suicidal behavior. And that includes specific positive social engineering approaches to change public attitudes about the importance of committing social resources to the prevention of suicide and to convince community members to change their personal behavior. And I think these types of programs that are universally delivered really do that in a way. They target stigma, they target literacy, mental health literacy. And, I think that those are really quite important goals. And they could really, if delivered upstream and, earlier on in development, they could really have an impact. And I had the opportunity to work a little bit with the National Association of State Boards of Education. Their policy lead, Megan Blanco, is just amazing. And she wanted to write about empowering youth to prevent suicide and different efforts that states are doing across the country to focus on youth-driven approaches, either programs delivered directly to youth or things that young people are doing in this field. And so we have a brief policy update focusing on this, very short, just 2 pages, but here you can see it. And it was directed at school boards and hopefully wanting this to be delivered to schools within states, just to learn about what others are doing in terms of pandemic relief funds. For at this time, schools have more money than they typically do, have had in the past because of the CARES Act funds and different pandemic relief resources. And so we thought it could be a good opportunity to let states know about these different range of programs that have evidence to support them, including teen mental health first aid, which has emerging evidence in the United States. Another thing that's worth mentioning is that John Mann, who is a leader in the suicide prevention arena, published a paper back in 2005, like the state of the science, what works in suicide prevention. And it was a really good paper just to get an overview of what works and what doesn't. And then he recently updated this paper about a year ago. And one new, kind of new thing that was in there is that that wasn't in the previous version, so it's sort of based on emerging evidence or emerging research, is that by delivering programs directly to high school students, they found that there was an impact on suicide attempts. Whereas the evidence based on delivering different types of gatekeeper training programs in general to adults in the building, the evidence is mixed. But this idea of delivering directly to young people seemed to have an impact, according to the emerging literature, on suicide-related outcomes in youth. And just to kind of dive in to talk a little bit about the Teen Mental Health First Aid Program, I had the honor and privilege to work with this program. And I want to just tell you guys how we got involved. The National Council on Mental Wellbeing released an opportunity to engage a research partner. And there was an opportunity that was posted and disseminated across the United States, and anyone could really apply to become the research partner for Teen Mental Health First Aid and working on this program. They had funding from the Born This Way Foundation, Lady Gaga's foundation, and we came across the request for a research partner, and we went ahead and applied, a team of us at Johns Hopkins. And we said, oh, this is an interesting opportunity. We love universal programs that are delivered to all students, regardless of risk. This program has a great evidence base from Australia. And the idea was to take the Australian program, bring it to the United States, and work with a lot of community stakeholders and youth to make adaptations to the program to make it fit our American context. And so we put in our application, and we were actually selected to be the research partner. And we've been working ever since. I think things are scaling back a little bit, but we've been working with the National Council for Mental Wellbeing since in this program, and trying to do a lot of the piloting and the research to support the program. So what is Teen Mental Health First Aid? It's a training program that was, like I said, developed in Australia. It's focused on 10th through 12th grade high school students. And it's a curriculum that was developed by Laura Hart, Anthony Jorm, and a bunch of folks from Australia, where they used an extensive process to figure out what the program should include. So, for example, when someone's in crisis, it's good to engage an adult, a trusted adult in that process, and teaching young people to know when something's a problem versus when something's a crisis, and when to engage a responsible adult in helping them, because they can't clearly, it's something that they shouldn't try to grapple with on their own. So that's an example. So they went through this whole process of what to include and what the core components of the intervention should be. And people with lived experience too were really at the table contributing to the content of this intervention. And there's some amazing evidence from randomized trials in Australia on this program showing the impact of it before and after implementation, and with youth in Australia in this age group, supporting the effectiveness of the program. And just to say, this program is focused on older youth, and for in the group that I typically work with, I'm trying to get even more upstream. And actually, Laura Hart in their group in Australia has a program that's for younger teens that we're sort of waiting to see. They've been testing it and have experienced some delays in the pandemic, but it's for 7th through 9th grade that age group. And so they've been working on the effectiveness studies in Australia, and we're waiting, trying to wait patiently for it to come to the United States, so it can be, we can go through the same process with that program. So what do teens learn? They learn to recognize the signs of developing a mental health or substance abuse problem, and to recognize the signs of a mental health or substance use crisis. So this is distinguishing when something's a problem and when something needs to be acted on more urgently when it's a crisis. And then using a 5-step action plan that emphasizes getting a responsible and trusted adult to take over as necessary. And those are the core sort of components of the program. And so this whole process started back in May 2018, when we started to get involved. And we were like I said, we were the academic research partner that was contracted with to help with the research elements. And then the National Council went through a pretty extensive process of getting experts that are names that many of you would recognize all over the United States, content area experts in post-traumatic stress disorder and depression and teen anxiety, and just a very diverse panel of experts weighing in on every single component of the program and making recommendations for everything that needs to be changed. And then there were focus groups of youth. There were 8 in-person focus. This is before the pandemic happened. There was extensive youth involvement in, looking at the graphics, like, are the graphics okay, and the wording. And, in Australia, they use the term mate instead of friend. And so there were like little practical things like that needed to be changed. And the Australian videos that they had for Teen Mental Health First Aid were so fantastic. And when I watched them, of course, they're all the young people were in those videos were white. And we were like, okay, this is definitely not going to work for us. We need, to change this and they're speaking in Australian English. And so it's a lot of practical things like that we noticed had to be changed. And so the Lady Gaga's film production company that she works with reshot the videos that are part of the program, because the program has, kind of a PowerPoint components that's at a limited, but it's a lot of interactive using a workbook and, kind of all different components to it, including videos. So it's engaging and interactive in that way. And the videos that were reshot are also, I thought for sure they were never going to be as good as the Australian videos, but they're really quite good. And one video, I'll skip forward. I can come back to this in a second, but just to say that these are the different components, and all these were adapted and changed to fit our context in the United States. The teaching notes, the manual, the PowerPoint slides, and in training, when you get these things, they're all updated. Trying to keep what worked from Australia and trying to keep the core components of it, but updating it so it's more impactful and fits our setting. And there was content added about substance abuse and addiction, additional content to the Australian version of the program, more on school violence. Unfortunately, that's much more of a prevalent issue in our context, and the impact of traumatic stress and social media, cyberbullying, and so forth on adolescent mental health. And the other thing that's different from the Australian version is our bell schedules differ. And so having the program accommodate different bell schedules in schools. So it can be implemented in 6 45-minute sessions or 3 90-minute sessions. And I think it's also for 60-minute sessions. And so there's different formats to fit the setting within a school, and there's an implementation toolkit that goes along with it. And so this is kind of, you can see what the materials look like. It's very IKEA-esque, I think, the Australian version, which is all the way to the left. And this version that's here, the action plan that's given to students that they're taught on what to do, was some feedback the American students provided was that it looked a little childish. And so they wanted a more sophisticated graphic. And so it was changed to use what you see in orange, the Teen Mental Health 5-step action plan, in more of the orange and gray graphic. And on the bottom of the slide, you see what's called the recovery position. And this is one thing that, students, like I said, it's very interactive, and students learn how to actually do this recovery position. If somebody is intoxicated and is on their back, students learn to position that individual so that they don't choke. And yes, and so that's like one thing that they actually demonstrate in the classroom. And this on the right-hand side at the top, these are the two main characters in the video, one of the key videos in the program, and it's just a fantastic video. The young person, the teen that's on the left is in the video, was extremely suicidal and at home in bed, and just completely wasn't responding to social media by the friend that's to his right, to our right, in the jean jacket, who was worried about the friend, texting him, and the friend wasn't responding. He hadn't been in school in a couple of days. And so the storyline goes that this friend takes a proactive approach, goes to the home, and finds his friend in bed and visibly extremely depressed. And he has a conversation with him that builds to him asking him if he's thinking about suicide in a direct way. And they kind of model what to do and how to have that conversation and what to do after. More importantly, what are the steps that you kind of do in the aftermath of finding out that information. After each session, and there are other videos as well, there's another video that demystifies mental health treatment for students. So they go through different treatment providers and different students who've sought help from different treatment providers and what that looks like. And it's a way to not make that process seem like an enigma. And so it's nicely done. And after each session, students were given an exit ticket. And that was just to make sure that the material wasn't triggering to the students, because they're students that, that we worked with as part of this program and testing it, that in the past had experienced these things themselves or by a family member or friend. And going over this again and hearing about it and talking about it had some mild triggering impacts on students. And so just making sure that the school setting is able to help those students experiencing any kind of mental health impacts as the result of the program, and being able to know who's experiencing symptoms and get them help. And so the role that we played is we helped the National Council conduct a expanded pilot, and a randomized trial to evaluate the US program. That was the modified version from the Australian version, was tested in various stages. And these are the stages that we were involved in. And then the idea was to conduct a pre-test and post-test to be able to assess adolescents' mental health literacy, skills, and confidence in providing the program in carrying out the action steps with the peer that they identify as experiencing a mental health problem or crisis. And the way this was done in Australia is that the students are provided with vignettes. There's a vignette on John, a student named John, who is experiencing depression and suicidal thoughts. And so the students are given this vignette. Your friend John, and the story is kind of laid out for them. He's, feeling this way. He tells you that he's thinking about suicide. And so there's that vignette. And there's another vignette on Jeannie, and Jeannie has anxiety. And so there's kind of like different problems that are presented to them. And this is the vignette on Jeannie, and she's experiencing social anxiety, and it's kind of aligned for them. And so they respond to questions based upon John and Jeannie and their symptom profile. So they're taught, of course, to recognize people that have these problems, and they're taught what to do when they encounter people that have these types of profiles. And so in the work that we did with the National Council, there was an application process that was sent out to all of the mental health, except in Maryland, all other states that were where people were trained, all the trained instructors within the mental health first aid network. They all got the application materials. And so some schools and communities applied, and sometimes it was school districts and sometimes it was individual schools. And then there were youth serving agencies that also applied. One example of that is there was some agencies like NAMI. NAMI Delaware applied, and there were church groups and synagogues that applied to youth serving agencies, and different community groups and agencies that applied to participate and be trained in the youth version and implement. And so they were part of this pilot study. So like I said, we had intended to do a randomized trial, and unfortunately the pandemic school closing impacted what we were able to do. Because we started this project in 2019, the training was in 2018 and 2019 of the instructors. There were quite a few instructors trained. And when many of them got to implement before school closures, and others were not able to implement before school closures. So what we wound up doing is taking the data that we had and doing an extensive matching schools to one another, and having a control school and an implementation school, and using the post-test data from the implementation schools and comparing it to the control schools pre-test data, because there was somewhat of a staggering, and we did this in waves. And so we matched schools on these characteristics that you see listed here. And 44 high schools were included in this process, although many more high schools implemented, but were included in the matching process. And about half of the schools had the instructors were internal to the schools, and about half were external. They could be mental health providers working in WITNAMI or other community agencies, and they came in as outsiders to the school and implemented the program. It was a nice range across of who the instructors were. And over 2,000 students provided survey data to us, but many more provided the pre-test than the post-test. And so the surveys before and after the implementation of teen mental health first aid assessed how students would respond to peers with clear suicide risk, and that's John, feel confident helping a suicidal peer, John, but also an anxious peer, and when to suggest that a student speak with an adult or get a mental health professional involved. And in terms of our sample of 2,000, this is the characteristics. Many states, not all states, but a lot of states participated in this pilot study. We had pretty good representation across the United States. And you can see the characteristics of the students. We had a range of students in terms of race, ethnicity, and nice broad representation, and in terms of sexual orientation. And this is a pretty dense slide, but the thing that I would like you to say is these are kind of the constructs that were examined in Australia. Like after the program's implemented, we wanted to change helpful intentions and decrease harmful intentions. An example of a helpful intention would be to notice John, this is the peer who has depression and suicidality, to notice that something seems wrong, and to tell him that you notice that something seems wrong and that you want to make sure he's okay. So that would be an example of a helpful intention, that you have engaged John in a conversation, and a direct conversation about how he's doing. An example of a harmful intention would be to ignore the person or to avoid asking about suicide because you're worried you're going to put an idea in their head. So that would be, harmful intentions, ignoring and avoiding. Confidence helping, so students were asked how confident they would feel engaging in these action steps. And there was a number of questions that were related to stigma, which I love, because you think that's part of the pathway in engaging people in their own help seeking. It's important to think about demystifying mental health treatment and reducing stigma. And so there are a lot of questions that kind of gauge that area. And so what we found is that you can see that the mean, this is before, the mean before and after. So pre and post, the means changed for these domains. And one way to look at it is what we call an effect size. So what was the impact pre-post? And the effect size of about 0.8 is large, and this column with D is the effect size. So a large effect size is 0.8. So we didn't get anything that was large, and a medium effect size is 0.5. So you can see for helpful intentions, the impact there was pretty solid. That was where we saw a lot of the impact. One thing that we found is that many of the American students in grades 10, 11, and 12 could recognize the problems. They were really good. 98% of them could recognize a depressed peer and an anxious peer and a suicidal peer. They were very good at recognizing, much better than the data was better for the American students than the Australians, because we included some older students as well. The Australians focused mostly on 10th graders, where we included 10th, 11th, and 12th. And so you could see the findings are a little bit weaker for some of these other areas, but I can tell you from my 35, years in this field is that stigma is a hard thing to change with a 3 to 4 hour program. So the idea that we were able to find a significant impact for many of these aspects of stigma was pretty solid, I thought. So we were seeing changes, even though these students are older and than some other programs implement. So this also shows you some data that, of course, of interest to us is, would students ask John if he's thinking about suicide? Would they directly ask? We ask students, would they do that? And in their pretest, about 15% said they would take initiative and ask directly if he's thinking about suicide. And post-test, we found about 40%. But you have to figure this is a very stressful thing for even adults to do. And so I thought that it was it was a pretty significant finding to me. It stood out as something that I thought was good. Of course, we want to measure actual behaviors, and we'll do that in the future. Avoid talking about suicide because it may put ideas into his head. So this is a harmful intention question, and you can see the change pre to post. Encourage their peer to speak with an adult about their situation. You can see the change from pre to post. But another thing is that we asked instructors and students if they would recommend the program to others, and the vast majority, 92% here, would recommend the training to a friend. And this is among teenagers who sometimes can be a pretty surly group. So the fact that 92% said yes, they would recommend it is, I think, a pretty good accomplishment. We also took advantage of the pandemic by also asking the participants if they had encountered any friends during the pandemic who had experienced a mental health challenge or crisis, and if they were able to use their skills to help a peer during the pandemic. And this was among a small subset because some students we just couldn't reach and weren't able to reach during the pandemic. Their schools did not want us reaching out to them. But of the students we were able to reach, it was 200 to 300 students out of the over 2,000 we worked with. A subset of students responded to our survey. And what we did find is in this probably biased sample and not representative sample, that the kids that did respond to us, it seemed like they were using the skills that they learned from the teen mental health first aid program over the pandemic, when I believe they needed these skills. It was important to have these skills. So in terms of the requirements for implementing teen mental health first aid, when we did the pilot, what was required was that all students in one or more grade level within a school. So schools could select all 10th graders, 11th and 12th, or they could pick one or two of those grade levels and implement across the entire, universally across the grades. So schools picked what they wanted to do in terms of implementation and how they wanted to stage it. And then it was required that sites must train at least 10% of staff in youth mental health first aid, so that we knew that adults within the building were prepared to be able to identify and assist youth within their setting and support students. And sites must ensure safety by doing the exit tickets. And they sent us to my house, actually, because of the pandemic. I have all their exit tickets. So it's really interesting to see those data. And that it was required that the schools have mental health professionals on site while courses are taught, so that they can act on the exit tickets and that they're there, just so in case students wanted to engage with them as a result of the program or in general. And so just in terms of progress to date, I just got these numbers from the National Council a couple of days ago in terms of how many young people have been trained in the teen program. And here you can see that over 82,000 students, almost 83,000 teens have been trained in this program in the United States to date in 600 sites. And there are over 1,300 certified teen mental health first aid instructors. And this program is, like I said, it's relatively new. It's just getting out there. And I'm wrapping up right now. Just in terms of summary and future directions, I think this is a highly practical program. I think it can be pretty embedded into health education class in many school settings. And I do think it aligns with the national health education standards, and it does align with our Maryland health education standards as well. What we need to do in terms of the research is we tried to replicate what was done in Australia, and we did. Our results are really similar to what they found in Australia about their program. I think what we'd like to do is to partner with all of you potentially in the future, and thinking about implementing and studying the impact of this in Maryland. We also want to learn who benefits and under what conditions, and also study the quality of implementation and fidelity over time, and to better understand what needs and what instructors need and what schools need to be able to deliver this program year after year with high quality of implementation. And of course, there's also the need to have stronger and enhanced connections between school systems and the healthcare system once students are identified within school settings. There's a really unique opportunity right now that I've been really thinking about, and President Biden signed the Stand Up Act in March of 2022. And this Stand Up Act was something that Sandy Hook Promise and I believe the Trevor Foundation really worked, their legislative liaisons really worked hard to get this passed this year. And so the Stand Up Act does provide $35 million for student-directed suicide prevention. And this is directed at students, not the adults. The adults in the building can be trained too, but direct education to students delivered. So the teen mental health first aid program does align, and other programs do as well, with the direct training of students on suicide awareness or prevention. And I think this program would fit the bill for that. And the Stand Up Act focuses on 6th through 12th graders, and it has a pretty broad definition of what's considered evidence-based. And so I do think that we could work to think about there'll be money for the Stand Up Act through Project Aware, and to how to think about disseminating this program throughout the state using these Stand Up Act funds. And I will stop there and thank you all so much for your attention, and just wanted to show you the names of our research team at Hopkins who worked on developing and adapting this program, and the folks at the National Council for Mental Wellbeing have been great partners. And the Australian team, Laura Hart specifically, and Tony Jorm have been great in helping us with the adaptations and the research here. And the Born This Way Foundation support was also very critical. And there were so many students who participated and helped contribute to the piloting of this work. And here you see Lady Gaga, and she was in Las Vegas, Nevada. And this is the student advisory group for the teen program, who she invited to meet with her and her mom and her team in Las Vegas, Nevada. They all traveled there with their parents, and they told her about their experiences with the program, what needs to be changed. They didn't mince words. And they all were invited to her concert, and they were on the stage. So these are all teen mental health first aiders in the advisory board, and they were on the stage with her at her concert, which was extremely exciting. And there are videos of that on YouTube if any of you were interested. But I'll stop there, and I think we have some time for questions, if any of you have questions or feedback of any type.
Holly, I think I just saw one question in the chat. which was regarding the cost of teen mental health first aid. And I don't know if you'd be able to speak to that. I think Anne would also be a good resource if you're interested in teen at all, and would be able to provide more specific information about the program.
Yeah, I mean, I do have a vague idea of what the costs are. I think they vary across settings. Here it may be different from the National Council's costs. I mean, one thing that we've been trying to do is trying to so that schools can receive this intervention in an equitable way. We've been trying to emphasize to the National Council how important it is to try to keep the prices low as possible so that schools can afford to sustain this program over time. So I don't know, Anne, if you want to jump in and just talk a little bit about the costs in Maryland.
So there are manual costs, $12.95 a person for the manual costs. There are also costs to have your instructors trained. The council is currently bundling the instructor cost with a number of manuals so that an instructor will get trained for a price, and then there'll be 125 manuals included. We at the Mental Health Association Maryland are currently in negotiations with the National Council to get a memorandum of understanding in place so that we can deliver this program here in Maryland, at which time that cost structure may change. So we're still sort of in flux with that. So stay tuned.
One thing to mention about the costs is that the booklets are quite expensive, and the program would be more affordable if the booklets, if there was something we could do to make the booklets more affordable. And one thing we thought about is, you know, it would be ideal to have an app. If students, instead of the booklet, they're so good with technology, if all that material is on the app, but we were told by the National Council that they really do, because they're writing in the booklets, and the booklets are a very important component of the program, and they can take that physical booklet home and they can use it as a reference. Yeah. But it's not just teen mental health first aid. You see the same thing with other programs, that sometimes the booklets are a heavy lift for schools to sustaining the program, to come up with that money year after year.
I see a few other questions here in the chat. I think we'll have time for just one more. So I think there was a question about ninth graders, if ninth graders were included in the research and why they may not.
Yes, and there were components of that. That's a great question. And this program focuses on 10th through 12th graders. There's some content that it was thought that is kind of required a level of maturity, like the recovery position that I showed you guys, where the student overdosed and they're on their back, and one student goes up and positions them with the pillow behind their back. And so it was thought that some of these more required a level of maturity, that this program is for an older, but there is an adaptation that is coming very soon for 7th through 9th graders. It's similar to the program that I presented on today, but it will be more developmentally aligned with that 7th through 9th grade age group. And so the National Council, I think, is waiting to receive that program, and it will go through a similar process, we believe, to what I presented on today, with the cultural adaptation, the local adaptation of language, with the variety of people that weighed in on the content, and changes made to make it fit our culture and our context.
Wonderful. Well, thank you so much, Holly. We have to move to the next piece because I know we have breakout rooms that everyone's really excited for, but we're so grateful that you were able to join us and share about the work that you're doing in this space. So much of what makes mental health first aid in all of its forms a really exciting program is that we do look for an evidence base and want to make sure that our programs are as rigorously tested and implemented as possible, and as culturally competent as possible. I've seen some other questions in the chat, and I think our team is trying to answer a few of those questions. I also really recommend that there was a FAQ that Leah dropped in the chat. So go ahead and check that out as well, and some of those answers may be in there as well. But thank you so much, Holly, for joining us. And as we move to the next section, I have another trivia question for everyone. So again, first person to put their answer in the chat will get the prize. The question is, what day of the year is World Mental Health Day? Okay, Katie Mack, correct answer, October 10th. Every year it's October 10th, which is kind of tricky because I know Mental Health Month, Mental Health Awareness Month is May, but World Mental Health Day is in October. So great work, everyone. And we'll go ahead now and get into our breakout rooms. So for the breakout rooms, we're gonna have 4 rooms. And Holly, thank you for throwing your email in the chat. If you all have any questions or you want to discuss anything with Holly, you can go ahead and reach out to her at her email there. We'll also be sending out an email after the summit, and you can always just reach out to us and we can connect with Holly for any questions that you have. So the breakout rooms are listed here. Room 1 is about vicarious trauma for the mental health first aid instructor with Angela and Anne. Room 2 is teaching mental health first aid to specialized populations with Julie and Marcie. Room 3 is marketing yourself as a mental health first aid ambassador, which is really regarding kind of small business marketing considerations. And then room 4 is more of instructor office hours. So if you know you're a newer instructor and you're trying to navigate Connect or some of these other pieces for instruction, room 4 may be good for you. And then I will be here in the main room if there are any technical issues. So the breakout rooms are going to run until about 1:55, and then we'll bring you all back in here. There will be an optional networking activity from 2 to 2:30. So if you're interested in staying on for that, please do. If you have to hop off at 2 o'clock, no problem. So what we're going to do in a minute here is we're going to open the breakout rooms, and you should be able to select the room that you want to be a part of. And you can go in there yourself. I'll also be here in the main room to help assign people if you need help getting into the breakout rooms, but we will go ahead and open those up in a second. And I think Leah will be pasting the evaluation link in the chat here in a moment as well, so that you all can also get that link. So I think everyone is right now unassigned. Go ahead and join the group that you want. They should be labeled as well. And as a reminder to our presenters, please make sure that you record your session.
I'm sorry, what button do you press for the breakout rooms? Because I don't see any.
Okay, Deborah, you have a preference for your room. Which room would you like to be in?
Let me go in room 4 because I have a couple questions.
Okay, let me go ahead and put you in there.
I will also be joining that room shortly. If anyone else wants to drop in the chat where they'd like to get placed, we can manually move folks as well.
Yeah, Leah, this is Angela. I just don't see my name up there.
You are in room 1, Angela.
Oh, did you already put me in there? I don't see my name to move myself.
Let's put you in, Angela. I think you should.
Gotcha. Thank you. Appreciate it.
So how do I also move into a room? Because I don't see a button that I need to push.
What room would you like to move to?
Room number 3.
Indu or Leah, it's Marcie, and I apologize. I don't see my name to move me into room 2, please.
No problem.
Think for anyone who has co-host properties, you can just click join.
Oh, thank you.
And
I'm sorry, my I can't type on here for whatever reason. My phone's acting crazy.
That's totally
Can you move
fine.
me?
Which room would you like to be in?
Room 1, please.
all right, anyone heading to room 4? I'll be there in just a second.
Yeah, I can handle the rest, Leah, if you want to jump out.
Okay, I got one more direct message.
Linda, you want to be in room 2. Room 3.
Great.
Thank
I'm
you,
just-
everyone. Thank you for your patience.
Excellent. All right, well, you know where to find me.
All right, we have a few more people here. Room 3. A few more people here. Yeah. Okay. So I have Sue, Matilda, Linda, Patricia, and Stephanie. You all want to put in the chat where you want to go? If not, I can just randomly assign you to a room as well.
I did put it in the chat. It's
Sorry,
Linda.
I might have
I
missed
asked
it.
for room 2.
Room 2. Let me put you in there. Sorry about that.
Oh, and then I was trying to close the chat thing and I just hit not now. So
Okay,
could you
let me do that again. Are you in now? I think I have you in there.
Yeah, I don't know how to get there now though, because when it asked me if I wanted to go, I accidentally clicked the not now.
Okay, give me one
There's-
second.
There we go.
And wait,
Thank
let me
you.
move you again. Hold on. Let me move you again. You want it to be room 2 or 3? 2?